Thank you, Senator. Senator Thune.
Thank you, Mr. Chairman, and welcome, panel. Nice to have you here. Thanks for your answers to our questions. I want to direct this to Mr. Glazer and Mr. Fadig. I'm sorry. Yeah, that's right. And I want to mention your testimonies that you had talked about the need for extending Stage 2. And I think last week it was at this, we had an IT hearing with the administration where I asked them about extending Stage 2 to give more time to address some of the very issues that you raised in your testimony. The administration wouldn't commit to it at the time, and I'm concerned that they don't have a realistic view of the problems that are facing this program, particularly in rural areas. And so my question is, do you think there's a way to design such an extension to give some providers and hospitals additional time in Stage 2 while allowing more advanced providers and hospitals to be able to move on to Stage 3?
I mean, I have, when I was a chief information officer in my 22 years of being a chief information officer, implemented provider order entry 11 times and did the ambulatory record for 4,000 plus physicians across the board. And that has taught me to have an extraordinarily healthy respect for the challenges of implementing these systems. These are hard, these are difficult, you have to be careful with them, you have to bring the medical staff along, you have to be thoughtful about the workflow. Healthy respect. So I think, Senator Box, back to one of your comments, I think I would hold feet to the fire. I might give them more time, but we got to recognize this is really difficult to do, and we want them to do it right in lots of ways. So what I would do is say, if you want the additional year, take the additional year, but that's it. You know, it's not 5 additional years, it's 1 additional year. If you're ready and on course and things are going well and this, that, and the other, terrific. You know, go ahead and meet the deadline and carry forward and move on to the Stage 3. But for those who need the extra time, let's give it to them, respecting the magnitude of the challenge that they have and the criticality of getting it right in a lot of ways here. I think they're going to be, and I'll let my colleagues speak, but I think they're going to be a special set of considerations for the rural, the community, the critical access hospitals that in addition to time might need some resource help. It's not just a question of time. It's a question of more effort, whether it's people or money or whatever, so that even with the year, they can stay on course and to make the care improvements that have been cited a couple of times during our comments today.
Thank you for the question. I think it's critical that first of all, we stretch out the timeline to 3 years at each stage, regardless of which stage it is, that all hospitals and the vendors all need at least 3 years at each stage so that we can do this right. And I don't believe we just need an extension at Stage 2. I think we need an extension at Stage 1 so that those hospitals who have not met Stage 1 objectives can meet them. 65 of the hospitals in Nebraska are critical access hospitals. If we're going to have an electronic record that includes all the data on these patients, we have to move the vast majority of those 65 critical access hospitals forward and not leave them behind with this digital divide. By stretching out Stage 1 for another, so that those hospitals who have attested in 2012 have an additional year to get Stage 1 right before they move on to Stage 2, I think would be very, very helpful. Also, maybe we need a grant program or a loan program for these programs. Make it something so that they have the resources to buy to get the initial investment so that they can move forward and help and increase the compatibility of all these records across the nation.
Yeah, a lot of those critical access hospitals in Nebraska are like the ones in South Dakota that I'm thinking of when asking this question. I would direct anybody that would like to take a shot at this, but Stage 1 of meaningful use required that there was no actual cross-platform exchange of information. Stage 2 requires only one instance of information sharing, and that can be with a dummy server set up by the government. Do you think the administration has put sufficient pressure on vendors through the certification process to advance cross-platform exchange of data? And a follow-up to that would be, what else could the administration be doing to encourage vendors to exchange data?
Go ahead. I mean, I think one is, I think there should be more pressure on the vendors to do this, and count myself as one, and to show that we can do the standards, compliant with the standards, and certified relative to the standards. So I think that is part A. We should realize that it is that in and of itself is not sufficient. What also should be occurring, across the board, is a continued movement of the payment model, which will incent not only the fact that you can technically do it, but you clinically do it. There's motive to go off and to do those kinds of things, et cetera. So I think there is a continued movement on the reform, broadly speaking, efforts to change the payment mechanism to reward quality and efficiency. The third, and I realize this can be tricky, is to give ONC and CMS more authority to move on the standards. At times they're stuck in a consensus process. I give them more clout to call it a day, because sometimes they have to stop short of a full definitive standards and leaving too much ambiguity or unable to call it as they need to do this. So I think there's three prongs: pressure on us as vendors, working with the payment model so that there's reasons for the organizations to, and it's not just connecting things, there's workflow that has to be changed, and who does it, who deals with the data, how do they do this, and how do they do that, et cetera. And also giving my colleagues at ONC and CMS more authority to further the standards development and codification process.
Do you think that there's a sufficient business case for continued progress on interoperability and exchange of data between unaffiliated providers? I mean, is there something else that can be done to ensure that there's from a hospital standpoint and from a provider standpoint, a sufficient business case to do this? I mean, apart from the government incentives, you know what I'm saying?
I believe there is. I believe there is, especially with the changes that are coming down with the Affordable Care Act. When we form our ACOs or our value-based purchasing groups or our clinical collaboration, we're going to have to be able to share data in order to meet those models, so the business sense is growing as we speak.
Yeah.
Go ahead.
I would agree. I think the private sector is already moving forward considerably on these new accountable care arrangements, and they're already needing to share information. And so aligning those information sharing conversations and methods with what we're seeing here in meaningful use would be very important. And even as we wait for those to take broader hold, hopefully through the Medicare program, through all of the performance measures that are being used today, I think there are opportunities to improve the use of electronic data that comes from electronic health records in order to populate those. So there are other ways to incentivize this in the system.
Yeah, I think you do see it now. So I might say as a health provider, I want to work with you two to form a clinical affiliation to deliver cancer care or whatever it might happen to be. And you're two separate organizations in my community, and we need to set up an exchange in order to manage this population. So you'll see that. Clinical affiliations, relationships will lead to this. You see health systems that say, I need to fill my beds, and so I'm going to have connections out to these doctors and that doctors to facilitate the admission process. And I want them to use my lab and radiology department, so I'm going to get results back out there. So there's clearly an exchange going on. And in fact, the health information exchange market, if you just look at sales of this thing, is really growing quite rapidly. The problem with it is that it's idiosyncratic. It's patchwork. So I've got you two, but I haven't dealt with you guys because I don't have a clinical relationship with you. And one of your patients might arrive here. Beats me, what went on there. So what do you
do about that?
Well, I think right now it is the motives. It goes back to the motivational structure. So I think part of what you do is you say, listen, I'm going to change payment, whether it's accountable care, et cetera. So it covers all of this stuff. It's not just this cancer arrangement. It's the broad coverage of care and accountability for care that occurs. And so I move market incentives that increase the broader value to the adoption, to bringing people in.
What would those incentives be?